Cerebrovascular accident, stroke. Stroke or cerebrovascular accident is the onset and persistence of neurologic dysfunction lasting longer than 24 hours and resulting from disruption of blood supply to the brain and indicates infarction rather than ischemia. Strokes are classified as ischemic or hemorrhagic. Pathophysiology and etiology. Partial or complete occlusion of the cerebral blood vessel resulting from cerebral thrombosis due to atherosclerosis or embolism. Number 2, ischemia related to decreased blood flow to an area of the brain secondary to systemic disease such as cardiac or metabolic disease. Number 3, hemorrhage occurring outside the dura, extradural, beneath the dura mater, subdural, in the subarachnoid SAS or within the brain substance, intracerebral. Number 4, risk factors include hypertension, transient ischemic attack, that is DIA, heart disease, elevated cholesterol, diabetes mellitus, obesity, carotid stenosis, polycythemia, and cigarette smoking. Number 5, cardiac causes of stroke account for approximately 20% of strokes occurring in clinical manifestations. Clinical manifestations vary depending on the vessel affected and the cerebral territory if perfuses. Symptoms are usually multiple. Headache may be a sign of impending SAH, that is subarachnoid hemorrhage, and cerebral infarction. Number 2, sudden severe headache due to spontaneous SAH, subarachnoid hemorrhage, is usually the result of rupture of an intracranial saccular aneurysm or arteriovenous malformation. It is cataclysmic, heralded by severe headache, meningeal signs, and neurologic dysfunction. Numbness, paresthesia, weakness, paresis, or loss of motor ability, plegia, on one side of the body. Numbness is paresthesia, weakness is paresis, and loss of motor ability, plegia. Difficulty in swallowing, dysphagia. Aphasia, expressive, receptive, global. Visual difficulties of inattention and neglect, including loss of half of the visual field, double vision. 7th, altered cognitive abilities and psychological effect. 8th, self-care deficits. Diagnostic evaluation, carotid ultrasound to detect carotid stenosis, CT to determine cause and location of the stroke, cerebral angiography to determine extent of cerebrovascular insufficiency, PET MRI may be done to localize ischemia. PET, positron emission tomography, MRI, magnetic resonance imaging. Management, acute treatment, support of vital signs or functions, maintain airway, breathing, oxygenation, circulation. Second, reperfusion and hemodilution with volume expanders, dextran, and thrombolytic therapy with tissue plasminogen activator, TPA activase, and vasodilation with nimodipine, that is nimotop. Third one, management of increased ICP. And fourth one, diuretic treatment to reduce cerebral edema, which peaks 3 to 5 days after infarction. Fifth one, calcium channel blockers to reduce blood pressure and to prevent cerebral vasospasm. Subsequent treatment, anticoagulation after hemorrhage is ruled out. Prothrombin time levels are reported in international normal ratios, INR. Anticoagulants are adjusted to maintain an INR at 2.0 to prevent stroke and the associated complication of intracranial and subdural hemorrhage. A report of INR, that is international normal ratios, that are elevated to reduce the risk of bleeding or decreased levels to adjust therapy to be more effective. Second one, antiplatelet agents such as ticlopidine or aspirin. Third one, antispasmodic agents for spastic paralysis. Fourth one, a rehabilitation program including physical therapy, occupational therapy and speech therapy as needed. Fifth one, treatment of post-stroke depression with antidepressants such as selective serotonin reuptake inhibitor citalopram. 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 Complications: aspiration pneumonia. Second one, dysphagia in 25% to 50% of patients after stroke. Third one, spasticity, contractures. Fourth one, deep vein thrombosis, pulmonary embolism. Fifth one, brainstem herniation. Sixth one, post-stroke depression. Thank you.